Hi guys, my name is Brandon Ayres. I'm from the Cornea Service at Wills Eye Hospital and Ophthalmic Partners of Pennsylvania, and over here will be my financial disclosures. Now I've been thinking about the turducken recently, and that is a chicken and a duck and a turkey, or a duck and a chicken and a turkey. It's a duck and it's a chicken and a duck and a turkey. It's the turducken. Two other things that are put into a turkey. And it got me thinking about how many things can you put into a capsular bag, especially when cataract surgery has been done some time ago. So I found a case that needed an artificial iris in a poor fellow who ended up with cataract surgery, had a floppy iris, and was left with a large iris defect. So he had to be returned to the operating room, open the capsular bag, put in a CTR, put in an artificial iris, just like the duck and the chicken or the chicken and the duck. All right, so let's just get right into the operating room and check out this case.
All right, and so here we are in the operating room. You can see this case, large temporal iris defects due to floppy iris. Our first mission is to dilate the pupil, so we're going to make some small incisions and place some flexible iris retractors. And that does reveal that this is a toric IOL, so we're going to put some positioning marks on the cornea just to make sure we don't lose our orientation. Now the trick here is making sure we get the capsular bag open. So lots of OVD and making sure we don't overpressurize the anterior chamber. We want to open the capsule all the way around because we're going to have to place a capsular tension ring, as that is not that easy in an eye that's had surgery some time ago.
Now hear me out, guys. It's different when you're placing a CTR in the capsular bag when there's already a lens implant in there. If you put the CTR in clockwise, the leading edge of the CTR is likely going to hit the haptic of the IOL, and it will try and rotate the lens implant.
And this is just one example of that, where I'm placing a capsular tension ring into a capsular bag where a toric IOL already was placed, and I'm going clockwise. You can see as I advance the capsular tension ring, which I'm doing quite slowly, you'll see the IOL rotate because the leading edge of the CTR is probably bound up on the haptic of the IOL. So now I have to rotate this implant almost all the way around to get it back on axis. There's got to be a better way than the way I did it in this case.
If you put the capsular tension ring in counterclockwise, it will hopefully slip right by the haptic, not rotating the lens.
And so that's exactly what we do here. You'll see we're holding on to the leading edge of the CTR. We're putting it in counterclockwise, so hopefully it slips right by the haptics, keeping our toric IOL on axis. Now also, the IOL is still somewhat fibrosed in at the very terminal bulbs, but you'll see that CTR go in, and although there's a little trauma to the zonules, it goes in without rotating our toric IOL. It stays right on axis. You can see that here. Now to put the artificial iris in, we really want to stain the capsular bag, so I'm going to put some trypan blue in, and then I decided to do more. I don't usually like to just spray the trypan blue in, but here I thought it was the best way to get a good staining of the capsule, and we'll rinse it with some BSS. Now we're going to really deepen the bag. I want to push the IOL back, so we're going to take our now tree-fine down fiber-free artificial iris. We're going to fold it over on itself and put it into an IOL inserter. Now, once again, OVD into the capsular bag, and I'm pushing the IOL back, and I'm lifting the capsular bag so that we can get the leading portion of the artificial iris right into the capsular bag. The leaflets almost never go, so we'll use 2 microforceps and carefully unfold the leaflets, getting them into the capsular bag. And then typically the last portion is pulling on the subincisional portion, folding it over, and getting it in the bag like you see here. Now the hooks will come out, we'll get the OVD out, and we have got this turducken done.
All right, so that's it. That's the ophthalmic turducken. There's a lot going on in this case with lots of new techniques. I certainly hope you learned at least one thing that you can apply to your own patients to make their lives better. Thank you so much for watching.